message qu'on a pour If you can join us, please. Je vais passer en français, ce sera plus facile pour moi. Pour une session importante sur le financement dans soit des pays à faible revenu, soit dans des situations également de crise ou de difficulté, que notre région et que le monde en réalité vit, qui demande des préparations et qui demande, je le rappelais hier, de l'innovation, au-delà de la générosité, de l'innovation également dans la manière d'aborder ces questions de financement de la santé dans des environnements qui sont un peu en difficulté ou des environnements qui sont secoués. Donc je pense que cette session est extrêmement importante compte tenu du contexte que nous vivons et compte tenu également des enjeux majeurs de la santé pour construire, chemin faisant, un lien social qui donne une perspective d'avenir à nos populations, aux populations de notre région, aux populations d'Afrique, aux populations du monde en général. L'éducation comme la santé sont les deux piliers indispensables pour construire dans un monde qui est en mutation, dans un monde qui est confronté des fois à la violence, de cette globalisation, de cette mondialisation. Donc, comment concilier des enjeux et des attentes légitimes du citoyen par rapport à un système de santé face à cette aspiration de la couverture de maladie universelle pour les citoyens face à ces difficultés de financement. Donc, je pense que je vais vous inviter à vous rejoindre si vous pouvez. If you can join us, please. And I will give the floor to Mr. Golem. Yeah, please. Thank you.
Good morning, and thank you very much. Thank you for the introduction and welcome. My name is Brendan Allen. I'm the Executive Director of the Global Alliance for Surgical Obstetric Trauma and Anaesthesia Care. We're an advocacy organisation advocating for the neglected surgical patient, focusing on low and middle income countries. Today I'd like to, I'm very pleased to be able to present on funding surgical services here at the conference. Can I have the presentation, please? Okay, thank you. I apologise to the translators for my accent. I'm Australian and not American, so if people have trouble understanding me, I apologise. Not for not being American, but for bad accents. I'd also like to note, because I've taken several slides for my presentation, I'm also an honorary fellow at the Nossal Institute for Global Health at the University of Melbourne. The Nossal Institute is a research institute that focuses on health financing and health governance in low-income countries. The presentation today will just include a brief introduction of the Global Alliance. I'll also speak about global surgery and its role in universal health coverage, and of course about funding global surgery. The Alliance is a member-based organisation. We currently have over 75 members from around the world. They include NGOs, federations, academia and the private sector. Again, all organisations are focused on core aspects of global surgery. Anaesthesia, trauma care and obstetrics. Our mission is to advocate for the neglected surgical patient. We have a vision of universal access to quality surgical care, and we do this by providing a platform for our organisations to engage and support increasing access to safe care. We're based around what we have defined as three pillars: advocacy, policy engagement, and resource mobilisation. The resource mobilisation or healthcare funding or surgical funding is the pillar that I'll focus on today. The key point of this slide is the 5 boxes at the bottom of the screen. This is essentially our work products of messaging, national goals, targets and indicators, international standards and guidelines, a data platform to capture operative case data, and one to track partnerships and synergies. I'll discuss that in more depth in my second presentation. And essentially we're advocating for safe surgical and anaesthesia care for 80% of the world by 2030. This again is aligned to the SDGs and the Universal Health Coverage Program. So I'd like to discuss the global surgery landscape and its role in universal health coverage. There's been several important and key moments for global surgery. In 2015, the WHO resolution recognised the role of emergency and essential surgical care and anaesthesia as part of the universal health coverage. There's been an increasing collaboration among international organisations in support of global surgery and advocacy. The knowledge base for global surgery has increased dramatically over the several years with the DCP3 and the Lancet Commission on Global Surgery being published. Again, the Lancet Commission was early 2015 and DCP3 was released several years ago. We've also found that an increasing number of countries are prioritising surgery as part of their health system strengthening programs. And of course the G4 Alliance was launched in May of 2015. And I should mention that Dr. is also on our governing council. Oops. So the WHO resolution stated that member states should prioritise essential surgery and anaesthesia procedures at first referral centres, promote access to medicines and equipment, carry out regular monitoring and evaluation, health curriculum and workforce strengthening. The DG, Director General, urged people to facilitate collaboration around prevention, screening and implementation of surgical care. And there's a report back to the WHO at the next WHA in 2017, with countries expected to report back on their progress to advance surgical care. So some numbers, and why are we focusing on surgery and anaesthesia? Currently around the world, 5 billion people do not have access to safe surgical care and anaesthesia. The world's population is something like 7 billion, or just over 7 billion. So the vast majority of the world's population do not have access. And in 2010, nearly 17 million lives were lost due to untreated surgical conditions. There is a cost to increase appropriate surgical services by 2030. The estimated cost is $350 billion. If that's not achieved, $12.3 trillion is the estimated GDP loss if low and middle income countries are not able to invest in surgical care. This map indicates the proportion of the population without access to safe surgery. You can see Africa and South Asia are the core centres who do not have appropriate access to safe surgery. So essentially, the poorest 1/3 of the world's population only receives 6.3% of all surgical procedures worldwide. So some more numbers. 33 million individuals face catastrophic health expenditure due to payment for surgery and anaesthesia care each year. This catastrophic expenditure relates only to surgically treated conditions. 48 million cases of catastrophic expenditure are attributed to non-medical costs of accessing surgical care, loss of income, transportation, accommodation. A quarter of people who have a surgical procedure will incur financial catastrophe as a result of seeking care, and the burden of this catastrophic expenditure is highest in low and middle income countries. And of course, a disproportionate burden applies to those living in poverty. Again, these slides are from the Lancet Commission on Global Surgery. And this slide, similar to the earlier one, indicates a surgical deficit of 143 million procedures per year. This is based on 5,000 procedures per 100,000 population. So 28 to 32% of the global burden of disease can be attributed to surgical conditions. And thanks to Dr. Mokdad yesterday with the fantastic discussion on the global burden of disease. This slide indicates how cross-cutting surgery actually is across the global burden of disease categories. So surgery interacts with communicable and non-communicable diseases, and of course injuries as well. The WHO have also developed an integrated management of emergency and essential surgical care, which identifies essential surgical services that should be applied at district hospital or first receival areas. These include amputation of distal proximal limbs, appendectomies, C-sections, cholecystectomy, laparotomy, hernia, hydrocele, and surgical correction of traumas, surgical management of acute closed open fractures and of wounds and burns. These obviously extend over the 3 bellwether procedures, which is a core set of procedures for health as a health indicator. So our argument is that surgery is actually a cost-effective intervention. Investing in surgical services is affordable, it saves lives, and it will promote economic growth. To meet present and projected population demands, urgent investment in human and physical resources for surgical and anaesthesia care is needed. Scale-up of surgical services that have been achieved by the best performing low and middle income countries. This was modelled on data from Mexico and Nepal, I think. 2/3 of countries would be able to reach a minimum 5,000 procedures per 100,000 by 2030. Without that scale-up, as I mentioned, loss to economic productivity is calculated or modelled at $12.3 trillion. Other studies have found various interventions to be cost-effective: cataract surgery, inguinal hernia repair, male circumcision, emergency C-section, cleft lip and palate repair. Equally cost-effective is the provision of surgery at small district hospitals with basic surgical services and larger hospitals offering emergency and trauma surgery. So the role of global surgery is increasing in universal health coverage, and one of the key UHC reports is the World Health Report from 2010. Universal health coverage can be achieved by extending coverage to the uninsured, including other services, and reducing cost sharing. It's a three-dimensional aspect of trying to achieve universal health coverage. The World Health Report of 2010 identified three basic problems: insufficient funding, low government priority for health, and inefficiencies. So how can we address some of these problems? It's important to understand the key solution is to understand context, and understand the context, and understand the context. One size does not fit all, and essentially we need to understand the applicability of potential solutions, be they surgical interventions, other healthcare interventions, or funding for each region, the country, and sub-districts or sub-regions. Countries like China and India, of course, have significant populations and require local level solutions at those levels. So, solving the problem of insufficient funding. Obviously, raising more funds for health or diversifying funding resources. Making health a high priority in existing government spending. This is part of the role of the G4 Alliance to advocate for increased funding from donors and governments, and supporting the governments of the countries that our members work in, currently over 130 countries, to make health a higher priority. Another key solution is making revenue collection more efficient, working with ministries of finance, tax departments and offices for more efficient revenue collection. Diversifying sources of revenue using innovative domestic funding. I heard yesterday the government of Libya has nearly one source of funding from oil resources. How does a country in that context diversify funding so they're not relying on one source? And of course, increasing external support. Low government priority for health, that's a difficult one to address. Obviously, we're trying to advocate for the prioritisation, evidencing the cost effectiveness of surgery and surgical interventions, and also understanding the role of health security as well, with an increased healthy population and associated rises in GDP. Another method of increasing government priority, although it's probably is a revenue generating solution, providing or maintaining adequate levels of financial risk protection, insurance and or other taxes to raise funds, pooling those funds, and obviously trying to minimise the reliance on out-of-pocket payments. Inefficiencies, improving efficiency and equity in the way funds are being used, trying to ensure affordable medicines, using those medicines appropriately, improving quality control at health services and hospitals, improving hospital efficiency, management training, leadership work, identifying and choosing the right interventions and finding incentives that work, be they for health workforce, be they for health interventions. Fundraising or forms of prepayment for safe surgery, no different to other universal health coverage or other income to support health services. So taxation. Philippines, Thailand and Ghana have applied a taxation component to raise health funding. general taxes, payroll tax, consumption tax, sin taxes on tobacco. Interesting, the WHO now has just called for sin taxes on sugar. Social health insurance policies, with the formal sector and civil servants utilising salary deductions have been successful in Thailand. Medical savings accounts in Singapore and China, and voluntary contributions and co-payments have been utilised in Korea, China, Philippines and Ghana. Oops. We also mentioned yesterday the role of national health accounts and understanding where funding is being spent. National health accounts support better understanding of the complex and diverse funding flows supporting the overall health sector. It also helps identify the magnitude, channel and allocation of external financing for health. This is a key area for understanding what funding and what costs are being applied to surgery at national levels. It's a key area that is not well understood currently. In line with WHA resolutions in 2011 on policy development and health system strengthening, it's critical that countries develop or update their national health sector accounts and national health sector strategies. We would advocate and urge all countries that this includes national surgical planning and incorporation of national surgical plans in health sector strategies and plans. It helps to encourage countries to base health interventions and evidence and enhance capacity to lead and coordinate health sector responses. Again, understanding where the money flows helps planning and coordination. The private sector is a key component of surgical strengthening, as it is of other health sector interventions. These next couple of slides are taken from some research undertaken by the Nossal Institute for Global Health, which focused at that time on low and middle income countries in the Asia and Pacific region. The increased role of private sector is associated with the development of particular characteristics in the overall health system. That includes porous and blurred boundaries between the public and private sectors, increased or high levels of out-of-pocket expenditures, low government investment in health, and weak regulation. These characteristics are often referred to as mixed health system syndrome and can result in significant obstacles in achieving public health goals, including equity, efficiency and quality of care. From an advocacy component, this research suggests that policymakers could shift their focus from looking at a dichotomy of public and private sector or seeing them as singular entities and view the issue as one of the management of mixed public-private health systems. Again, taking control of coordination and of a public-private mix. Innovative financing is a key health sector response or global response to trying to increase funding for health interventions. Innovative financing instruments do not replace but complement traditional resource flows such as official development assistance, direct investment and remittances. It can be used to address specific market failures and institutional barriers, mobilise additional resources, and it's estimated that innovative financing instruments have mobilised nearly $100 billion between 2000 and 2013. This includes Gavi, the Global Alliance Vaccine Initiative, other initiatives. Innovative financing is unique in that they can attract private companies wanting to expand into new markets and fund managers who want to create both financial and social returns on their investment and support governments that want to achieve constrained environments. One success model sponsored by Gavi is the pneumococcal advanced market pharmaceutical manufacturers. This set up the development and availability of this funding up front. The manufacturers agreed to sell the vaccines to low-income countries no more than 3 for the next 10 years. This is 90% lower than the cost of those vaccines in high-income markets. Again, another potential role. There are other models of innovative funding. Again, can only really be applied when you understand the context of the area that we're working in. And finally, I would raise the concept of a global surgical fund. This is something that we're discussing within the Global Alliance, and with lots of more questions to ask and analysis to undertake. Key question: do we need another global fund? Do we need one that's focused on surgery? If we do, what might that surgical fund look like? Should we model it on Gavi? Should we look at similar mechanisms as the advanced markets? Should it be included in a global fund system strengthening, which is a concept that Jeffrey Sachs is discussing? We don't know the answers yet. Your inputs into that concept would be very valuable. And that's the end of this. I'd very much, particularly to the Global Alliance, and recognise Professor Fizan Abdullah, who's the chair of the board of directors of the Global Alliance. Unfortunately, he was unable to attend this conference this year. And I'd also research supporting this presentation, but who equally are very committed to understanding healthcare funding.
Here, you will have probably many questions. Les chiffres, the numbers and the figures that you presented shows that we have to consider health as an investment and not as a cost for. Il y a un sujet qui, à mon sens, n'a pas été abordé, notamment dans ce contexte de mondialisation, c'est l'accès aux médicaments. L'accès aux médicaments dans des populations, dans des pays qui n'ont pas cette dépendance sous cet angle-là, qui fait que quand on regarde, si on prend la Tunisie, c'est vrai qu'on a à peu près 50% de notre consommation qui est produite par l'industrie locale. Mais néanmoins, il se trouve qu'il y a concomitance où il y a entre les pays qui étaient en rouge au niveau de la carte que vous avez présentée et l'absence d'une dépendance par rapport à l'accès au qui est important. Un point également qui, à mon sens, est important et parce qu'on voit que les évolutions du mode de vie fait que le mode de vie et les risques sanitaires évoluent avec ce mode de vie, notamment par rapport au tabac, par rapport aux addictions, par rapport aux drogues, par rapport dans un monde qui est en globalisation. C'est l'importance également et la connexion ou l'interdépendance y avoir avec d'autres secteurs. Le secteur et d'autres, de la culture et autres, pour faire en sorte que la prévention ne soit pas vue, ou que la santé ne soit pas vue exclusivement comme étant un secteur isolé, mais comme étant des enjeux de société, notamment par rapport à la prévention. La prévention qui va permettre de contenir cette évolution. On ne peut pas aller en fuite en avant et rester avec des coûts qui vont augmenter de plus en plus, avec des risques qui augmentent de plus en plus. Qui aurait des questions? Oui. Yes, please.
Oui. Bonjour. Merci, Monsieur le Président. Sherifa Hamar. Voilà. Je remercie le conférencier, mais j'ai été interpellée à plus d'un...
Juste, pardon, une seconde, le temps qui s'équipe pour la traduction. Merci à vous, vous pouvez reprendre. Merci.
Bien, merci. Donc, je suis de l'autre côté de la barrière, la consommatrice, donc, mais comme ma formation étant économique et que l'axe occipital de l'économie étant la santé, je suis également plus qu'intéressée par ce secteur-là. D'autant plus ayant eu le privilège d'avoir été la compagne, plusieurs bornes, du plus grand nom de la médecine arabo-musulmane, professeur Slaim Ammar. Bien, cela dit, je suis interpellée à plus d'un titre. Premièrement, que dans le cadre de cette mondialisation, qui malheureusement est une destruction silencieuse de l'identité. L'identité à travers une tradition et à travers un quotidien vécu par la population, donc la voix du terrain. La voix du terrain qui a sa médecine traditionnelle, qui a ses pratiques. Donc, Monsieur Alain, vous n'avez pas tenu, il me semble, et d'après ma compréhension, ce que j'ai compris, donc, que vous avez occulté totalement ce terrain-là. Or, il est quand même heureux de constater que vous avez répété 3 fois le contexte, c'est-à-dire le local, avoir une lecture à travers, je ne vais pas dire les oreilles du cœur, parce que là, ça balaye le côté matériel, celui des transnationales, des productrices de médicaments, alors là, parce qu'il n'y a pas de sentiment. Et c'est les chiffres, c'est les additions et les soustractions. C'est pas le souci, c'est pas l'humain. Voyons. Or, votre type de prise en charge thérapeutique occulte l'humain. Non, monsieur. Une économie est basée sur l'humain. Je suis désolée. L'humain, c'est lui le nerf moteur du pays. Et donc l'écoute doit être faite attentive. Et je vais dire même un peu plus loin, je vais aller un peu plus loin, avec les oreilles du cœur. Ça, c'est pas évident. Parce que les décidants, les responsables, les politiciens, ce sont des postes. Ils appliquent les directives. Or, les directives viennent de l'extérieur. Et l'extérieur, bon, c'est la même chose. Ils s'en foutent de Ali, de Rida et de Mohammed. Qu'est-ce qu'ils s'en foutent? C'est le fric, c'est toujours le fric. Ce sont les multinationales financières internationales sanguinaires, et je le répète, monsieur, qui encore bouffent le sang du peuple. Et merci.
صباح خير. دكتورة ابتسام القصبي جامعة الزاوية رئيس لجنة الليبيين اللاجئين. نقف؟
نقف.
اوكي.
نقف لتونس.
ابتسام القصبي رئيس لجنة الليبيين اللاجئين بتونس، القنصلية الليبية سابقا. السيد إيلين تعرض إلى القرار المنظمة الصحية. أنا عندي استفسار أتمنى أن يزودني بمعلومة. هل هذا القرار يشمل المهاجرين واللاجئين؟ لن أتكلم عن النازحين لأنهم سيكونون في بلد الجنسية وبالتالي سيشملهم. وعلى من يقع مسؤولية تنفيذ هذا القرار وتفعيله؟ هو على الدولة المستضيفة أم بلد الجنسية؟ أيضا لأن التخصص الدقيق هو IT، فحضرتك تكلمت عن الأرقام والأرقام المعروضة حول من لديهم مشاكل في النفاذ للعلاج. تتكلم عن هل هذه الأرقام تتكلم عن العالم بشكل عام، وهل تشمل ليبيا؟ وهذا ما رأيته من خلال الخريطة. وإذا كان تشمل ليبيا، هل هذه الأرقام بعد الثورة أو بعد أحداث 17 فبراير؟ وأيضا يهمني أن أعرف أين أو كيف تم التحصل على هذه البيانات، عن طريق الNGOs أو عن طريق الحكومات. تكلمت عن التحسين. هل لديكم كمنظمة أو كاتحاد آلية للوصول إلى هؤلاء على الأرض؟ تكلمت أيضا عن معلومة مهمة تكلمت فيها صباحا مع الدكتور سيد المهدي وكيل وزارة الصحة، هي المرأة ووضعية الولادات التي تحصل في مخاطر عالية جدا. في ليبيا حدثت ولادات في مزارع وتحت الأشجار وفي مستشفيات لم يكن لديها أي خدمات. كيف يتم هذا؟ هل كانت هناك تجارب من خلال الاتحاد في المناصرة حدثت فعليا على أحد البلدان؟ نتمنى ذكر هذه البلدان لنقلها. كيف يمكن تقديم الخدمات في المستشفى؟ تكلمت عن تقديم الخدمات في المستشفى. هل سيتم عن طريق تدريب الكادر الصحي؟ هل هناك آلية موضوعة لهذه التدريبات؟ هل هناك بلدان مستهدفة؟ شكرا.
D'autres questions dans la salle ou...
Thank you for your comments and questions. I'd like to address the concept of context. In particular, the Global Alliance is in countries that actual services, either supporting governments for service delivery, and it's our members that help identify the contextual of the work. We're definitely not advocating for we're advocating for strengthening national level health systems. So it's so important, and we need to reiterate that the Global Alliance's role is to collaborate and support the direction of national governments. We're not there to tell national governments which way they should move or where they should go. In regards to the numbers and the figures, most of the data and statistics that we utilise and that we use for our advocacy campaigns currently come from the Lancet Commission of Global Surgery and also from the DCP3, which focused on funding for surgery. The Lancet Commission has been criticised for the modelling of their data. It's not necessarily direct data at national levels, but modelled data. There's very little national level data on surgical expenditure, and that's one of the key aspects of our advocacy, and I'll mention it a little bit further in the second presentation as to how the Alliance is trying to address that data gap. Our members, I guess, do have experience and understanding of issues of childbirth and labour as questioned there. We see surgery as a component of primary health care. It's not a standalone activity. It should be viewed in the context of another health intervention alongside supporting village midwives, traditional birth attendants, nurses, who are addressing some of the key public health interventions.
Can you just highlight out of the membership that you have, how many of them are charities, how many of them are not-for-profit, how many of them are profit-making? Very important to you.
Okay, so the majority of our members are not-for-profit or NGOs, and the majority, well, actually not the majority. Most, if I can actually go back to that slide. We have currently two corporate donors supporting some of our work in East Africa, looking at national surgical planning, hospital management and leadership, and advocacy. Our other supporters or members are colleges or professional associations. Royal College of Surgeons of Ireland, for example, the World Federation of Societies of Anaesthetists, are large federations. Academic institutions are also involved, as are social enterprises. A number of our members have formed companies around surgical interventions or equipment, including safe anaesthesia equipment, specifically designed for low-income countries.
There is another question.
Merci. J'enchaîne. Merci pour la présentation, Monsieur le Président. J'enchaîne avec ce que vous venez de dire, justement. Je pose une question par rapport à l'activité ou l'intervention de l'Alliance G4 par rapport à la concrétisation et au soutien des différents pays pour atteindre l'objectif du millénaire, certainement, les objectifs du millénaire en lien avec la santé et notamment la réduction de la mortalité maternelle qui, en majeure partie, est affectée par l'insuffisance en matière de chirurgie, en matière de prise en charge de la femme enceinte dans toutes ses dimensions. Et essentiellement, actuellement, avec l'enchaînement des objectifs de développement durable et notamment l'objectif 3 qui englobe la totalité des interventions en matière de santé et de bien-être, comment évaluer l'intervention de cette alliance ou la participation et la contribution de l'alliance pour l'atteinte de cet objectif, notamment en matière de santé maternelle qui reste encore l'objectif non atteint par rapport à l'ensemble, à la majorité des pays actuellement dans le monde. Une autre petite question par rapport à l'accès à l'information. Et là, en termes de coûts, en termes d'apport aussi bien technique que en matière d'accessibilité universelle pour les prestations de santé et notamment les prestations en chirurgie, combien est-ce que ça a été évalué en termes de coûts et l'indicateur qui renseigne sur l'atteinte de cet objectif, c'est-à-dire combien on peut réduire, je m'explique peut-être, combien on peut réduire de cas en matière d'accessibilité à l'information si on a une bonne accessibilité à l'information, comment on peut réduire de cas qu'on peut éviter. Et merci.
Thank you for the question. I'm not sure if I'm actually able to answer that directly with adequate statistics and data. As an alliance, we haven't yet developed or understood how to measure the alliance's overall impact in addressing, in your case, maternal care. Again, the alliance utilises the resources of individual members rather than being an implementing body by itself. So we're the umbrella group to represent that. Again, though, we would be advocating, and I would certainly be calling for that understanding of reduction in maternal mortality or infant mortality to be understood at national level, and understanding what those reductions are through the overall interventions of the health service or the health system, rather than necessarily trying to understand the attribution of a large membership group. In the case of costing for particular interventions, again, the data is not that broad at the moment. I referred to in one of my slides to some of the cost benefits aligned to different interventions. Again, those have been specific country studies, but not all countries have undertaken those studies as well. Again, I'd be supporting our members and in their engagement with national governments to ensure that those data, statistics, evaluations are conducted appropriately within the country context.
منير والعريض الصحفي. تستعمل عدة شركات عالمية للأدوية، ومنها شركة كندية حاليا تستعمل في تونس وتقوم بتجارب على مواطنين توانسة، بعض المواطنين توانسة باستعمال أدوية، وذلك مقابل مجانية العلاج. فهل هناك قانون دولي يمنع هذه التصرفات ويعاقب تلك الشركات؟ وشكرا.
I'm not sure if I caught all of that question. I'm sorry. I understood from that a concern of foreign pharmaceutical companies trialling or testing medicines in Libya. Is that a correct summation? In Tunisia, sorry. I'm not aware of that particular example, and I would find it difficult to comment on that, certainly from the capacity of the G4 Alliance. I would expect, though, for all corporate organisations and corporates to work within the ethical standards of trialling and testing new pharmaceuticals, and certainly working with government authorities to ensure the safety and efficacy of any pharmaceutical trial.
Thank you, Mr. Allen. And now let's give the floor to Mr. Van Boven.
Good morning, ladies and gentlemen. My name is Erwin van Boven from IMRES, Netherlands or Holland. And I would first like to express my gratitude to Professor Oakley and the team that organizes this forum here in Tunisia for having us, our company IMRES, here this morning, and to sit on this panel for provision of healthcare during crisis situations and how to reduce risks in those situations. I must say, as IMRES, we do have some experience in this particular area, emergency preparedness and intervention. Although I must say that we also are active in a wider sense, that is, in a general provision of healthcare in lower and middle income countries all over the world. So we have both a generalist and a specialist role in global economy, in global health systems. And as to make that a little bit clear to you, I would want to introduce our organization to you by means of a short presentation. I don't know if it can be brought up on screen. No, this is not the one. That's the one. Animation? So IMRES Netherlands was founded in 1980, and step by step we have grown into a global leading company providing healthcare in developing countries. So we have expanded all over the globe by opening offices in various continents. So by now we are about a $100 million organization active in more than 130 countries all over the globe. We were set up 36 years ago with this mission statement. Basically, IMRES wants to make a difference in the global healthcare by providing high quality and yet affordable medical solutions. Medical solutions, I mean, we are a wholesaler of pharmaceuticals and a wholesaler of medical equipment and medical consumables. So we provide a wide scope of these items, and we have a logistical operation enabling us to provide those items in hard-to-reach areas. We have an independently run quality assurance and quality control department because, as per our mission statement, we want to be able to make sure that we don't compromise on quality for vulnerable people in these areas. And we partner with many UN agencies, UNHCR, WHO, UNFPA, UNICEF, as well as ministries of health in developing countries. Our partners are also the major international non-governmental organizations with a mandate for medical relief. Being a generalist wholesaler means that our product portfolio is extremely wide. We provide basically anything that you would find in a rural health center in sub-Saharan Africa or in a university referral clinic in basically any country. So we would be able to provide you with a simple painkiller like aspirin or a highly sophisticated cancer medicine, a simple wound plaster to a CT scanning machine. So it's the whole range, including itself a hospital. We provide mobile hospital solutions, so containerized hospitals on truck chassis or in tent-based hospitals too. You will find a chart here which shows a bit the distinction between the different product categories. So pharmaceuticals is the largest, but we also do a fair number of medical equipment as well as medical consumables. The black part of the chart contains medical kits, on which I will speak later, pertaining to emergency relief. We are not a pharmaceutical wholesaler providing just a box of a piece of equipment or a bottle of medicine. We like to be a close partner with the implementing agencies, being involved in the whole supply chain, which means from the very first start of budgeting a project, can be a malaria treatment program or a tuberculosis project, to the stock holding, local warehouse management, implementation, so training and servicing the equipment that we provide, getting the feedback back from the countries where we send the goods, so enable to improve our services. So all through the supply chain we can be involved. We do this from our facilities. We are headquartered in the Netherlands. We have 2 warehouses in this country, as well as a warehouse in Dubai in the United Arab Emirates. And we have local representative offices in many countries. I will show you on a map later on. So we hold about 10,000 square meters of goods warehousing of medicines. And we are about 100 people speaking multilingual services. So this shows our representation on the globe, and from the blue dots you can already see that our focus is in Africa. If you put that in perspective, percentage-wise, Africa is 2/3 of our activities, sub-Saharan Africa mainly, but also the Maghreb. Asia and Middle East is also a traditional area of our exports, as well as Latin America and the Pacific region. Coming to the specific topic of the panel for which I'm invited, that is intervention during crisis situations. Having been active for 36 years in developing countries, unfortunately we have of course come across many emergencies, whether they are caused by nature or man-made disasters, civil conflict, tsunamis, floodings, droughts, famine. And we want to be a long-term partner for the ministries of health in these countries, so we need to be able to answer during these emergencies too. So as a result of our mission, we are keeping large stocks of emergency goods in Dubai and in the Netherlands. So we stock up about $8 or $9 million worth of emergency pharmaceuticals and equipment, and this is mostly packed in medical kits, medical sets, trucs de médicaments. One of them, the most commonly used, is designed by the World Health Organization in cooperation with other charities such as UNICEF and Médecins Sans Frontières. This is called the Interagency Emergency Health Kit, or IEHK. This is a very nice concept because if you face a situation, whether in Libya or somewhere else, where the whole infrastructure, the health infrastructure is damaged or swept away, and you want to provide immediate medical care, you can send one IEHK, which has the basic necessities for 10,000 people for 3 months. So it's a very nice concept in the sense that it's costing less than $10,000, and yet it serves 10,000 people for the most common diseases, the most common affections, for 3 months. So this kit we will always have 24/7 available. We can send them out in 24 hours to any destination in the world. And this is the most common reaction during a crisis situation. An example or 2 examples where we have been partnering with people during emergencies is the 2015 Nepal earthquake and the 2014-2015 Ebola outbreak in West Africa. Both were, again, examples where we just didn't supply a box with a medical kit and say, good luck and we hope that you will do well with it. No, we were involved in the whole process of implementation, local reception in the port, airport, seaport, local storage, and making sure that the kits end up at the right destination. In the case of the Ebola outbreak, it required us to dramatically increase our sourcing and purchasing capacity, since the need raised tremendously, which was not so much in the picture during earlier epidemics, but for Ebola, this was key, of course, sanitation, hygiene. So we were called upon by the WHO and other NGOs to immediately provide high numbers of personal protection equipment, kits packed. And this was a challenge, but we managed somehow to alleviate the worst effects. Coming to an even more regional approach, the neighboring country of Libya. We have a long history in this country. Pre-revolution years, we were involved with the Ministry of Health to provide high-end medicine, because the level of healthcare in Libya was, of course, one of the highest in Africa, if not in the world. However, revolution occurred, and the major NGOs, they called upon us to provide emergency health care. And what we did as an initial response was to provide general medical kits to hospitals which were either destroyed or no longer functioning. So we sent out that IEHK, this Interagency Emergency Health Kit. That was a start. After this initial phase, we were called upon to do 2 things, actually. We had to anticipate a prolonged role of supporting Libya, because the conflict was not a very short one, but it may take longer. So we had to increase our stock levels dramatically, which is what we did. So by now, our stock levels are ready to meet basically any demand, either from Libya and surrounding area. But we also needed to understand better the specific requirements for this particular emergency. The IEHK, as I said, is a very unique and good concept, but it's such a general medical kit that it can also lead to unwanted products, medical waste, if you will, because it contains items for problems that may not occur either in Libya or on that specific spot where you send the kit. So there could be unwanted items in a general approach. So we try to listen to our partners in Libya, World Health Organization, International Rescue Committee, International Medical Corps, IOM, for whom we intervened in Libya. And they said we want a more customized approach. So we presented to them the International Red Cross Committee trauma sets. This is a modular set of medical kits, each with smaller parcels for a specific medical purpose. So if there is a specific high need for surgery items, they can choose that module out of the total package. Or if there is more need for anesthesia medicine, they can increase the number of anesthesia modules. So this allows our partners to be more flexible and address the proper needs, in this case, Libya. What we experienced, particularly in Libya, is that there is a high need for trauma surgery kits. World Health Organization has long time ago developed the so-called Italian kits, which contain medicines and medical consumables for performing surgeries in war, civil war situations. So these are in high demand. And of course, if you want to do surgery, you need to have a proper amount of anesthesia medicines too. So the third area where we saw a specific need in Libya was for obstetrical care. Pregnant women, small children, are of course amongst the most vulnerable group during a civil conflict. So we need to address that and make appropriate quantities of these kits for obstetrics, for deliveries, available to our partners. So for these three kits, the trauma, the anesthesia, and the obstetrical kit, we dramatically increased our stock holding levels. Now, during an emergency, you will need to be able to deliver the product in a timely manner. So we have, up to now, sent all our supplies by air charter into Labrak and into Tripoli. So we have pre-arrangements with air charter companies in Dubai, in Liège, and in Amsterdam, which allow us to immediately call for an airplane once we have an agreement with the implementing partner of sending medical goods. A final aspect, which I think links to the subject of this conference, is how to deal with the financial aspect of emergency preparedness. We find in all these years of activities that it's not so easy to motivate donors to invest in emergency preparedness, especially when it concerns medicine. The medicines that we supply have a shelf life, so you can only keep them on the shelf for so long. Yet you want them to be available immediately in quantities that are unprecedented sometimes. And you want them to be affordable. So you want them from low income, of low cost sources. So you need to invest in stock holding, whether it's popular or not. And we think we are seeing a trend whereby there is a partnership between public and private. We as IMRES are a private company, and we see the need for meeting that emergency demand. So we have invested a lot of means, time and money, and warehouse capacity to stock up on emergency goods. And luckily, at the same time, in the public sector, the NGOs, the United Nations, we see the same awareness. So WHO, they have now stepped up their stock holding level in Dubai, in Brindisi, Italy, and in our warehouse of medical kits. So they are making more funds available, even though they know that perhaps if these emergencies do not occur, they will have to throw away the medicine. So that's an investment that you make, and hopefully it will not be used in the sense of human suffering, but it's an investment that needs to be made. And at this moment, with 4 NGOs, we are having a shared stockholding agreement whereby we invest something from our own, they invest some means, and as a result, they will have 24/7 availability of items as and when needed. So this is what we learned from our Libya experience. I don't know, Professor Oakley, how much time we will need to leave for the second presentation of Mr. Allen and the WHO presenter.
Yeah, 3 more minutes.
3 more minutes.
Yeah.
Well, in that case, I will make a stop because I have a few more slides which deal with quality control. And I think quality control in this area, in emergency situation, is essential. It would deserve its own conference, speaking days on end about how to guarantee quality so that we avoid people getting substandard products during situations where they are already at a risk. So I can only say one or two things about the slide, how we guarantee the quality. It's a step-by-step independent approach whereby we do audits on a factory level, we do quality control in an independent laboratory, we do audits, recurrent audits, we do visual analysis, chemical analysis on the product. So we can't jeopardize the quality, because if people would die from substandard medicines provided by IMRAS, then we are done. This has resulted in a number of approvals by WHO, GMP, USAID approval. Various organizations have audited us, so this is very important to us. Second thing, the last slide maybe, our logistical possibilities. Of course, we can have the product available either in Dubai or in Netherlands, but to bring it to that specific spot in Libya or elsewhere requires a tremendous logistical effort. Again, it's a subject which I could talk on days, but I won't do that. We provide this logistical service at cost price. We just charge what the freight forwarders charge, but it's a vital aspect. So as I said, most goes by sea, but the emergencies all go by air. These are some of our partners, but I'd like to welcome new partners. If there's anybody here who would like to know more about our services, please feel free to approach me, ask me questions either now or during the after session, and I'll be happy to respond. Thank you for your time.
You have to say, you will probably have some question. Thank you, Mr. Boven. Some question, if you agree. Do you work with the local, let's say, CDCs?
Yes.
Yeah, this is important. And the part of the training as well, because
Yes.
you presented the kit, and it's not matter of only kit and etc., but also of preparation, especially in situation, not usual situation, to be prepared for something that the human can prepare himself, and the relationship with the local citizens as well. It is important, because you are in situation not usual situation, and you have also to have not only governmental counterpart in the countries, but also to identify which kind of organization in the country you have, especially when it's the result of a war or kind of war, like it happened in Libya or others. Unfortunately, this kind of risk will increase, especially in these regions. We know that.
Most probably.
And, yeah. And so it was my two questions, but I will take. Yeah, please.
Merci, Monsieur le Président. J'aimerais féliciter Monsieur Van Boven pour cette excellente présentation. Vous avez très bien parlé du produit. C'est super.
Merci bien.
Oui, c'est super. Vous l'avez très bien travaillé. Cela dit, vous avez 35 ans d'exercice, donc 35 ans sur le terrain. Lorsque vous avez agi au Népal, puis Ebola, et donc là, vous avez pris l'exemple de la Libye. La question qui vient à ma tête, c'est la suivante. Où êtes-vous? Est-ce que vous avez fait le Yémen? Est-ce que vous avez fait la Syrie? Ou le choix de la Libye a-t-il été influencé par le pétrole? Merci.
Qui a d'autres questions dans la salle? Je me doutais bien.
Désolée d'accaparer un peu la parole, mais juste une petite question par rapport à ce que vous avez vraiment présenté. C'est une très belle présentation et aussi très riche en informations. Sauf que ma question, est-ce que là, et d'après les constatations, d'après toutes les autres présentations, aussi bien hier qu'aujourd'hui, on voit qu'il y a des investissements dans le secteur matériel. Mais qu'en est-il pour les interventions immatérielles? C'est-à-dire en cas d'urgence, en cas de catastrophe, en cas de situation catastrophique. Il y a aussi l'assistance médicale, il y a aussi la prise en charge morale, il y a aussi peut-être les conditions d'hygiène à prendre en considération dans de telles situations. Donc, tous ces questionnements, il ne s'agit pas de donner le kit, mais il s'agit d'assister les personnes en cas de catastrophe et en cas d'urgence. Dans de telles situations, on a aussi bien besoin d'une intervention, d'une assistance matérielle, mais aussi d'une assistance immatérielle. Et c'est vraiment fondamental, surtout pour les populations vulnérables, notamment la femme, les femmes enceintes, les petits-enfants, tout ça, les personnes âgées. Ces personnes-là ont besoin peut-être d'une assistance et d'une intervention qui peut-être n'entre pas dans vos prérogatives, peut-être, je ne sais pas, je pose la question, qu'en est-il pour ce type d'intervention? Et merci.
Merci à vous.
Thank you, ladies, for your input. As to answer the first question, I made a small presentation of two larger interventions, Nepal and Ebola, that were recent. And of course, since we are close to Libya and people are, I think, here from this country, I chose to focus a little bit on this area. However, as we speak, my colleagues, I was on the line with them this morning, they are intervening in Haiti. There was an effort after Hurricane Matthew. There is a cholera outbreak in Haiti. So we are sending a rehydration module. As much as it's sad for these people, they are in a dire situation, and of course we can only be prepared maybe not for 100 emergencies, but the idea is about the investment on stockholding, that we earmark and reserve goods for that particular partner who has a mandate in, say, Libya or in Syria. So if people want to address the situation in Syria, they will have the goods always reserved for them. If another emergency occurs and they want to respond to, then there may be a challenge. But we want to be able to respond to all emergencies regardless of the destination. As to your question, I'm very much in agreement with your finding that it's not just making a nice show, sending a lot of items on the plane and saying, well, this is our donation to you, vulnerable people, and we hope the best. We cannot really afford doing that, because if it's in the news flash that after a few weeks some of the boxes, the hardware that we send remains unused or is disappropriately used, it reflects negatively on us. So we do have an interest in making sure that the proper training is given. We are what you would call a pharmacy for the world. We provide the medicine and the equipment, and we need the doctors of the world, Médecins Sans Frontières or Doctors Without Borders. We need them to partner with us to provide the medical transition of the knowledge, the training. We cannot do that ourselves. But if it's not happening, then it reflects negatively on us. So we want to make sure that the partners that we work with, either the Ministère de la Santé or the NGOs, they have the knowledge and the commitment to train the people for proper use of the medicine, of the equipment, because otherwise it's a waste of money. Then the donors will be less enthusiastic. They will say this is no good, this intervention, and then it it backfires on us. So we, as much as we can, we will ensure that the whole package will be provided to the people that needed it most. Thank you. Not? Oui?
تفضل لله تفضل.
أنا عندي سؤال.
يلا تفضل دكتور.
تفضل لله تفضل.
اوكي. انا كنت نبي نسال اذا كان في الامكان ان في تصوركم استحداث مركز خدمي لتقديم تدريبات وخدمات في داخل ليبيا، لان حاله ليبيا مش حاله مؤقته قدمتوا فيها الخدمات ثم خرجتوا، بحيث يظل هذا المركز مستمر الى حد العبور من هذه المرحله، لان يحدث تدريبات لمنظمات NGO ثم لا يحدث متابعة، يحدث تدريب ثم يحدث خلاص كل حد بعد التدريب يمشي في حاله، وبالتالي احنا نحتاج إلى تدريب ومتابعة، يعني تدريب ناس تقدم الخدمات وتستمر المنظمات الدولية أو حضراتكم كمنظمة لمتابعة هؤلاء والتأكد منهم هم يقدموا في الخدمات أصلا مش تلقوا تدريب وطلعوا يعني. هل لديكم فكرة لاستحداث هذا المركز في داخل ليبيا؟ شكرا.
I such a center for continuous training and education in Libya. I would definitely have a vision for that. It requires not only our commitment and energy and finance. Basically, it requires many different staff, medically trained nurses, midwives, and commit themselves in person for a longer period in Libya. And they will, of course, always question about so many people so benefit the Libyan population. I would need to get in touch with other parties who commit also. And we are in talks with International Medical Corps about setting up mobile hospitals which can move in different regions in Libya. And these need to be staffed with people who will commit longer term for Libya. So this may occur, it may materialize, but it's not in my own hands, unfortunately. But there are thoughts of doing such a thing, and we hope they will materialize, definitely.
I have maybe just two quick questions. Out of your total sale volume, how much is it goes to UN agencies or other agencies, and how much is for individual governments? Number one.
About 50-50.
About 50-50, okay.
Yeah, the UN is our largest partner, the different World Health Organization, UNICEF, but ministries of health are about 40-45%.
In that case, I think having a research center will be, you should consider as part of your research and development. Because when you sit down directly with the end user, not the minister or the purchasing department or tender committee, what you need to sit with is the people who open the packs. Number one, you need to train them how to open, how to use the kits, which is essential. Also, you will learn from you yourself as Emrys, you will learn from that end user, the people who open the box, the surgeon, the OR nurses, the pharmacist. When they open the box, you will learn. They'll tell you, oh, we have too much of that. We didn't have enough of this. Because we had generally positive feedback on the kits, but some negative feedback. And the negative feedback had always been deficiencies and not excess of anything. Because when your health system is broken and you have little supply, you probably, no amount of kit will replenish your native supply. But the difficulty is when you provide him of kit, which is okay to do a laparotomy, for example, but he doesn't have enough gloves or doesn't have enough gauze. And that's the lesson you have to learn. And you can only learn within the operating room in Benghazi Medical Center or the pharmacy in Tripoli or with the OR nurse somewhere in Sabha.
No, I couldn't agree more, Professor. We try as much as we can to get that specific feedback from our implementing partners, but ears and eyes and hands on the ground for a longer time will definitely help us much better to realize that. Yeah. Sure.
Thank you for the really excellent presentations. I'm Dr. Alamin, just aware of crisis in Libya. Are you aware of an area which is predominantly affected in Libya? Libya is a vast countries, huge countries, escape lands. I am aware of the peoples which is in Benouilid areas, and Tawarga has been moved everywhere in Libya, and far south in Obari, really a long-standing, ongoing crisis. Quite a lot of people need medical services, which is essential medical services, which is not available. Ministry of Health allocated mobile hospitals down there, but are you aware of area of Far, Qatroun, Al-Wigh, vast end of Libya in the south? Really is area which is quite affected. Thank you very much.
So I'm not sure if I correctly got your question. So you asked about our ability, our capacity to reach out to those far regions? Yeah.
That's the question, yeah.
Yeah. Now, getting the goods in a timely manner to the major ports, Misrata, Labrak, the airports, is already challenging. There is not so much transport capacity by air to the major cities at this moment. So leave alone the extra mile, the last mile into even harder to reach areas. If we find partners, implementing agencies, whether it's the Ministry of Health or IMC or IOM or WHO, who wants us to go there, we are capable of doing so. We will hire local forwarding companies, we will provide the security things that are needed to bring the goods there. But of course there is a price tag, an additional price tag to those services. And if there are partners willing to pay that extra dollar, then we will go there, definitely. Yeah. We are able, but it requires also the instructions and the finance of other parties to do so. Leave the floor.
Do you have another? Yeah. The last question, yeah.
Assalamu alaikum. Welcome to our country, Tunisia.
Thank you.
I'd like to thank you for your time and consideration. And during this forum, I would like to mention some points. First of all, we are in an international health funding forum. It means, first of all, let me tell you who am I. Ahmed Nasrawi, branch manager in a bank sector in Tunisia.
Yes.
The question is, during this forum, we didn't see some big lenders or bank who are present in this very important. For me, it was a couple of weeks waiting for this event to come.
Sorry, if you just 1 second. If you have question linked to the presentation and the subject, your question, you can ask your question later on.
Okay, I'll delay it. Thank you. Thank you.
Thank you, Mr. Boden. And,
Thank you for the opportunity.
voilà, je vais passer la parole à le prochain orateur, M. Benoît, qui va nous parler d'un sujet qui nous tient tous à cœur. Donc je suis impatient d'écouter ce que j'ai déjà écouté de ta part.
Merci.
Et je passe la présidence.
So I will start. Really, I will try to. My name is Benoît Mativet. I'm an expert in health financing policy, and I am currently the health policy advisor, the health systems advisor at the WHO country office in Tunisia. But what I will do is talk to you more as a health financing expert, having visited quite a number of countries and lived in a number of countries, helping the governments to strengthen their health financing systems. So it will not be focused on Tunisia. It will sum up a number of my experiences starting with my first few years in Central Asia and Russia, and then a short stay in Libya in 2013 as part of the Libya Health System Strengthening project, and then the few years I spent in Geneva helping a number of countries as part of the UHC partnership funded by WHO and funded by the EU and WHO. So I've been asked to be very practical. So it's not going to be very conceptual. It's going to be mostly a number of key messages. If I may have the presentation. Oh, yeah, sorry. Yeah. So really, it will be mostly, what I will present is a bit of concepts. Yes, this. Okay. Yes, so a few concepts, but not too many. First, a definition of what is UHC. I'm so sorry I couldn't be here yesterday, but I was on the field in Bizerte for a project on improving management of quality by hospital directors. So, but I'll come back to this definition. What are we aiming for when we're talking about UHC for a country? We mean that we aim at a state of the health system when all people are able to benefit from health services they need, whether they are preventive, promotive, curative, rehabilitative, or palliative care, of a sufficient quality to be effective. I really repeat the quality side because basically that's something we often forget. And the use of these services should not expose the citizens, the people, to financial hardship. So we should basically, if we aim at UHC, we should aim at policies which limit out-of-pocket payments. I can come back on this briefly on the 3 dimensions, but they were presented before. The idea is that you need to, the objective is to maximize the cube in these 3 dimensions, so cover as much as the population as I can, but actually 100% is the goal. On the services, cover as many services as I can, so define the widest possible package depending on the means, available. And the financial protection limits out-of-pocket payments in order to guarantee financial protection of the people. And we know that roughly a system that guarantees between guarantees that only 20 to 15% of total health expenditures are covered through out-of-pocket payment. A system that reaches this level is actually protecting people decently. You reach a level of financial protection that is optimal at this level. What is interesting with the cube is that you can insist on the fact that you can work in sequence. You can work one dimension after another. You can make progress on the 3 dimensions, not everything at a time, because basically you have to make trade-offs depending on your available financial and physical means in a country. So there is an idea that the march towards UHC is a long march. There is an objective as part of the Sustainable Development Goals of 2030, and the idea is that this march will be made of trade-offs depending on the given on the available resources at the given time. Yet, the first key message I have from discussing in a number of countries is that okay, you can make trade-offs and you have to progress on one dimension of the cube at a time, maybe, but pushing too much in one direction without taking into account the 2 other dimensions is actually ruining the process. And especially in a number of countries, the effort has been put on guaranteeing 100% of coverage, which meant that, okay, everyone has a card, and everyone is part of a small scheme, so you have dozens of small schemes not talking to each other, and actually the problem is that the guarantee behind the enrollment in a scheme is 0, is virtual because there was nothing, there were no resources at the beginning to basically strengthen the service delivery system. And even in countries which made many progresses over the last 40 years in ensuring a proper service delivery model and ensuring a high level of coverage, sometimes you need to come back and say, okay, what am I achieving in terms of UHC? And if I take the example of Tunisia, for example, Tunisia, attained a very high level of coverage between the two main coverage schemes that Tunisia has, the AMG, the free medical care for the most vulnerable, and the mandatory health insurance, the CNAM. The coverage in Libya is roughly of 90% of the population. So you can think, oh, we reached UHC. And actually, part of the effort of the Tunisian government right now is to say, okay, I reach a high level of coverage when it comes to the amount of population covered, but people, for a number of reasons, are still paying a lot out of pocket. They still pay 40%, roughly, 37.5% of total health expenditure come from out-of-pocket payment from people. So what are the reasons there for this, and how do I solve this? So you have always to work on several dimensions of the cube. I will be fast on this one. What I want to is just, how does health financing policy and the functions of the health financing system contribute to reaching the goals of universal health coverage? So what I want to show you with this graph is that first, on the left side, what I want to really highlight is the fact that health financing is not just about the amount of money that you collect. Money in a way, I'm a health economist, and in French we have this, it doesn't translate very well in English, but it's money is the nerve of war. Okay? Money is the nerve of war. If it was just, and it's really relevant in the health system and pouring the funds through the system, if it was just about collecting money and job is done, it wouldn't be a nerve. It would be just an artery. So I'd like to consider myself as a neurologist rather than dealing with blood vessels. We are dealing with money. You're not dealing only with the flow. You're dealing with incentives. So it's important there because what matters is not just what you collect, but how you pull it, how you gather it in order to guarantee equity, and how you channel it from the pool to the providers in order to incentivize them for quality and efficiency. You do all this to guarantee a certain benefit package to the population. And by doing this, you fulfill a number of intermediary objectives of UHC, which is equity in resource distribution, efficiency, transparency of accountability, and accountability. And the final goals are, as in the definition, that people should get what they need of a sufficient quality and without being ruined. Then comes a second message. So we've seen the functions on the left side. Okay, here I have an example from Moldova, a country I supported a few years ago while I was in Geneva. You see that in Moldova, they have what they call a system of health insurance fund. And the resources of this health insurance come 55% from the state budget, 43% from employers and employees' contributions, and some minimal contributions from the self-employed. What I want to ask you here is that, can we call this a health insurance system? Some people, when they say this slide, say that, okay, it's 55% funded by the state budget, so it's not health insurance. What we mean by health insurance is that it should be fully contributory and it shouldn't be subsidized. But actually, who cares? In fact, the problem with health financing these days is that you have too many labels and not enough thinking on functions. And what matters is that basically people feel insured. What matters is that, you know, a citizen knows that they can access the system without financial burden. And this doesn't depend on the structure of the funds that flow in the system, as long as it is mostly prepayment. You can't say that someone from Britain, you know, who received services as part of the NHS, which is mostly budgetary, doesn't feel less insured than a French citizen who received his benefits funded through a mandatory health insurance. The label doesn't matter. And it's part of a broader message that actually you shouldn't seek a system for its name or for itself, but just for what it triggers in the broader health system in terms of incentives. So what really matters? What matters to reach UHC is certainly to base your system on a compulsory source. No matter if it's payroll-based or if it's, you know, direct or indirect taxation, as long as it is sufficiently progressive and that it drains a reliable amount of money over time. And it really depends on context, as we were saying. You know, basically, you cannot ask your system, especially a mandatory health insurance system, to be more effective at making people contribute than the tax system itself. You know, basically, if a country is unable to levy taxation from its own citizens or its own companies, the mandatory health insurance system won't be able to be more effective at levying individual contributions. So maybe you have to think, okay, if I can't introduce a mandatory health insurance system based on contribution, I can imagine a high share of subsidy from the state budget, whatever the source of this budget. What also matters is that all who do not contribute are subsidized by this budget. And when I'm saying all, is that because we are really talking about universal health coverage. What I've seen in a number of countries where there was a very high percentage of informal sector workers was to say the informal sector is hiding its money from us as a government. They can contribute, but they don't because they're saying these people are benefiting from social services apart from that. Secondly, anyway, what do you do if hypothetically you can locate them? Do you kick them out of everything and are they paying for themselves? Then you're not moving towards UHC because basically you're excluding a huge share of the population from any safety net for health. It's not the purpose of UHC. So basically first, certainly when it comes to covering the informal, and having the informal contribute, the fact is that you need to acknowledge that it's difficult and costly to locate people who should contribute and don't. It's costly, it might not be a lot of people compared to the total population of the informal sector. In most countries, low income and middle income countries, actually it's a tiny share of the informal workers who is actually rich enough to potentially contribute to MHI. So basically, if it's too costly, let's just subsidize everyone. You know, everyone that doesn't contribute so far. And after that, with growth and everything, people may have in the future an incentive to basically declare their activities, and you'll get them in the formal contribution system. What matters also is to ensure a wide level of pooling. Basically, what we don't want, and I was talking about this earlier, what you don't reach UHC by having a huge amount of tiny pools, because in doing so, you don't build a strategic purchaser in your system. You don't build a purchaser which has enough power to influence the providers for quality and efficiency. And certainly, if you leave people you know, as individual purchasers of care, you know, if the patients, even subsidized, are put in alone in front of the provider, they will never have the power to influence for quality and efficiency if they are alone, even subsidized. About purchasing, and I'm nearly done, every purchasing mechanism creates positive incentives for the providers, but they also come with a number of drawbacks. So an incentive which is very good at, a mechanism which is like per capita funding for primary health care, which is very good at bringing the money where the patients are, bringing the money where the population is located on the field, may have, you know, the drawback of désincité, basically discouraging the providers to provide quality. Other, you know, if you have other mechanisms like result-based financing, which are very good at providing quality, but they alone, they are not enough to basically send the money where it is needed. So basically, the idea is to talk about these mechanisms, to think about these mechanisms applied as bundles, you know, together in order to synergize between their positive incentives and negate one another drawbacks. So, and also in doing this, you avoid, in thinking about purchasing mechanisms in terms of bundles, you avoid this flavor of the month dimension that you have. Quite often donors driven, you know, for basically from the late or the middle 90s to the mid 2000s, per capita funding for PHC was a flavor of the years of the decade. Then RBF came, and RBF was the only funding mechanism that was going to do everything by itself. And actually, you see that basically the government is able to tell donors, no, sorry, I think that this is, you know, this model is interesting, this purchasing mechanism is interesting, but what we did before was also interesting. So how can we work on both together? And you also need to think on the influence of a purchasing mechanism, not on the level that it funds, but also how the various purchasing mechanisms influence the patient pathway through the system. For example, in Russia, when I was in Russia studying the Soviet healthcare system, which was basically they received, and the hospitals were paid based on basically, and then because of the level of the health system, but actually at several levels, and sometimes we, you know, that's normal. We have a priority of mobilizing more resources and doing better quality for primary care, so we only think about primary care. And separately, we talk about hospitals, but actually we need to talk across the level of the health system. Finally, and this is my final slide, what my key message is that you have to keep health financing policy simple. Actually, a health financing system is not desirable in itself. If you ask a patient tomorrow, what do you want for your health system? The patient will say, I want better care. The patient won't tell you, I want mandatory health insurance. And actually, that was very visible when in Tunisia, in from 2012 to 2014, there was this dialogue sociétal, so civil society involvement in defining the vision and defining the priorities of the health system for the future health system reforms. People were not really talking about health financing. What they were talking about the quality and the proximity of care, you know, the availability of good care nearby. They were talking about the fact that they had to pay for medicines, especially in the private about the Libyan case here, the main innovation, the main vision one government should have is about its service delivery model. The service delivery model is the first thing you need to think about. It's actually what you want to offer to the population and at what level. And after that, based on what you want to provide to the population, you think about a health financing system that incentivizes the good behaviors within the service delivery model. And one last point, in order to do so, you need a lot of work on evidence generation in the country, and especially homegrown analytical capacity. I understand that you talked about national health insurance yesterday. In 2013, when I was there, I wrote the first terms of reference for the national health accounts work. In Tunisia now, the Ministry of Health is really pushing for having up-to-date health accounts every year. And this is really paramount to have good evidence in order to ground sound health policy. So, and you can start with small things. The idea is that if you're in a state where you have problems gathering the data, you can still ask good questions. And I want to just finish on the fact that in Libya, I know that, and like in Tunisia, I know that there are a lot of very good, motivated junior people at the ministry who want to learn and want to be very good analysts of health policies and health financing policy. They are there. It's just a matter of identifying them, motivating them, and basically raising their capacity. And I'm very optimistic for the two countries when it comes to this special point. Thank you.
Thank you, Benoit. Thank you very much. Don't run away, stay. It's always nice to have the WHO on board because it gives you some optimism. They're always optimistic about things. A few things I have to state that after this we'll have a coffee break. So the more questions you ask to Benoit, it will delay you from the coffee break. Number two, immediately after the coffee break, we'll have, for the first time, we managed to get hold of a minister who is an economist. He's an economist, but he's now a minister of health, which really is actually will help us to assimilate what happened in the last 2 days. I'm very honored to have His Excellency Minister of Tuvalu to speak after the coffee break. So please be here in time. We'll try to bring you back maximum 11:45. So if you finish your coffee early and come back here as soon as you could. We'll go back to your discussion. I have tried to, actually, I have invited Dr. Alwan, who's the director of the Emiri office in Cairo, but unfortunately there was a change in leadership in Cairo and things very little time for him to hand over, so he could not be here today. Also, Dr. Hussein is in Geneva, so we are honored to have Dr. Benoit to talk to us. Even it's only one lecture, I wanted him to give 2, but he escaped. He managed to Skype with 1. You're talking about healthcare financing. It's not how much money you bring in, is how you spend it, which was a fantastic discussion yesterday about that. But also sustainability. I think I wanted to add the third dimension when you talk about funding health. Is it going to be sustainable or not? And as you said, in Russia, there's moral hazard. In hospitals, the longer you have the patient in the hospital, the more money you will get back. Hence, you will keep that patient in the hospital as long as you like, because every day he comes, just add more money. Universal health coverage is, I'm glad you tried to put a definition to it, because I was in Geneva where we were talking about UCH, or UC, and I was more eager to coin the term health system strengthening rather than universal health coverage, because the problem with the health system really, which is broken, if you have a broken system, I don't care how much universal health coverage you're going to give me, because the priority for me is to have a strong health system. This was all about. But Margaret Chan, the DG, was adamant it must be universal health coverage, and it happened. She beat me. And I admit defeat in public. So I really, the question is always, how does the WHO propose to implement this? Because it's a very vague term. Now, in India, we have probably millions of people who need a heart transplantation, maybe a few more millions who need an artificial heart. A heart transplant costs you $100,000 US. Artificial heart will cost you anything up to $500,000. Are we actually excluding expensive treatment from universal coverage?
Well, on this one, I think, well, first the link between UHC and HSS and health system strengthening. It's important to think about UHC as a goal or as a kind of march, a path, and HSS is a set of strategies, plans, and priorities. I mean, you action health system and health system strengthening in order to reach the goal, which is UHC in a way. Then about rationing, clearly, what we have in the cube is to define basically a set of services which is at a given time affordable by the funds available in the country, whether they are public, and we try to extend the share of the public funding, while basically there is still a level of co-payment. And it's true that depending on the level of funding, public funding available to a government, to a ministry, they have to limit the basic benefit, the benefit package to a certain benefit package that is available to everyone for free or with minimal co-payment. So it's all, access to very high technology is still not impossible, but it depends on the other side, on the availability, on the capacity of the government to make it fit within the package by regulating the price with the providers and pressuring them for efficiency. So I think you could say, I have too little money to cover for this expensive surgery. That's one point, so I don't cover it. Or over time, you could think of maybe having more money, but this can be unlikely in some country settings. But on the other side, in a more active role for a Ministry of Health, you could say, in order to fit this surgery, this expensive surgery in my package, how can I basically negotiate with the equipment industry, with the pharmaceutical industry, with the providers I control, in order that it makes it fit within the package, that I push them for more efficiency and lower price on the lower prices of inputs.
With coffee in mind, any questions?
It's difficult.
Please go ahead.
Thank you. Excellent presentation. I just wanted to comment on the percentage of out-of-pocket payment.
Yeah.
I don't have statistics, but I think 30 to 45% is too low at the moment, because I have one indicator right now in Tripoli area, the big Tripoli area. There are about, I would say, 180 to 200, the last statistics by Maya Clinic, private clinics in Tripoli area.
Yeah.
So that's a huge number. That's one indicator that says how much people are paying out of pocket. That means the private clinics are doing so good in terms of business, so they are duplicating. And as we speak, clinics are being built right now. And so the out-of-pocket payment has been always kind of underestimated. So there is a capacity of the people to pay. And I'm not very sure how to use this kind of willing to pay and consolidate it with universal health coverage and accessibility and et cetera, et cetera.
On this point, just to clarify, the 37.5% was in Tunisia. It's because we have an interest from also the Tunisian floor and the Tunisian attendants.
In Libya, it's more.
In Libya, it's certainly more, and it needs to be.
Can you identify yourself?
I'm sorry. My name is Dr. Abdullah Fanir. I was working with the Ministry of Health in Tripoli, and now I moved to the private sector entirely. So.
Yeah. Okay, so in Tunisia, when in Libya, sorry, when the national health accounts will be calculated, I'm sure it will show a picture with much a greater share of out-of-pocket payment in total health expenditures. But and it's true, you know, the reference really that is a kind of empirical reference is when you reach 15% of out-of-pocket payment in a country, you reach a level of financial protection which is adequate. You may want to keep a bit of financial participation of patients. You may want this in order to, for example, limit overconsumption. But when you are at 15%, it's okay. Yeah, thank you. And
Thanks.
Please, je vous en prie.
Oui, merci. Merci pour cette présentation, Monsieur Benoît. Justement, je vais parler un peu pour ce qui est de l'accès universel aux services de santé. Et là, c'est un terme, c'est toujours relatif, c'est contextuel, on ne peut pas le déterminer comme vous voulez de le dire. Il y a un minimum, un seuil, il y a un panier à déterminer pour dire que vraiment il y a un accès à des services bien déterminés et qui sont couverts par la sécurité ou l'assurance maladie ou ce qu'on appelle, on peut appeler plusieurs choses par rapport à ça. Mais ma question est, est-ce que le financement de la santé ou de l'accessibilité aux services de soins n'est pas unique au secteur de la santé, et n'est pas unique au ministère de la Santé. Il y a plusieurs autres intervenants qui interviennent justement pour l'accessibilité aux services de soins de qualité. Il y a, sans citer d'autres, il y a l'accessibilité géographique, il y a l'accessibilité financière, bien sûr le niveau d'instruction, tout ça, ça entre dans le panier aux services de soins, parce que c'est ce qu'on appelle les déterminants. Donc, pour mesurer justement le financement ou le coût d'accès aux services de santé, il serait donc indispensable et imminent d'entrer dans les détails et dans les déterminants de la santé pour justement évaluer une question de bonne gouvernance et non pas de disponibilité de moyens, parce qu'avec des moyens moyens, on peut fournir un minimum d'accès aux services de soins. Et merci.
Je vous remercie pour méthodologie, ce qu'on incluait dans les comptes nationaux de la santé ou pas. Au-delà de la mesure, votre question, elle pose vraiment la question de l'intersectorialité et de la santé dans toutes les politiques. Et en particulier, il y a dans le processus de planification nationale, au-delà de la santé, il y a des opportunités pour la santé de faire valoir de la santé dans toutes les politiques. On pense par exemple au développement des politiques nationales de réduction des questions comme dans un pays, on m'avait dit, Benoît, à l'horizon 2015, 7 jours sur 7. Allumées dans tout le pays, elles s'allumeront, quoi. Et on me répond là-dessus, ah mais non, tu sais, à la campagne, les gens n'ont pas les mêmes besoins. Il faut se suffire de l'électricité. J'ai répondu à la personne, déjà, sur les besoins de la population elle-même à la maison, c'est relativement discutable, même ça a des impacts de santé publique, mais pour réfrigérer les produits dans l'hôpital de district ou dans le centre de santé de base, pardon, j'ai besoin d'électricité 7 jours sur 24 heures sur 24. Donc votre politique, il n'est pas assez bon pour la santé. De placer la question de la santé à un autre stade, dans tous les secteurs. Voilà. Mais merci.
بقي أن أشكر دكتور سعيد
الاجتماع من جديد، وهذا هو اللاست سيشن، فإن شاء الله يكون خفيف وسريع. فنستكمل بالسيشنز اللي تأجل من في one session تأجل من الصباح للدكتور ألين. He was going to talk about the role of NGOs and charities in healthcare financing. Dr. Allen, you are welcome to start.
Thank you very much. And the first session, I apologise for my Australian accent. I think this session I need to apologise for talking too long in the first session. And I'll promise to be shorter on this in this one. I've been asked to present the role of NGOs and charities in crisis and disaster risk reduction. I'd like to just note that I am not a disaster risk reduction specialist. I have worked in some crises and in the context in previous work with international NGOs. The G4 Alliance is not directly involved in disaster risk reduction activities. However, the work that we do in our health system strengthening approach, obviously with a focus on surgery and anaesthesia, is a key component to build resilient health systems. So in a risk reduction model, preparing the health system to be able to respond and to be strong enough to stay strong in an emergency response is important. So the traditional role of NGOs and charities in risk reduction programs or in emergencies is similar to what they do as normal business, so to speak. So that includes service delivery, training, advocacy, fundraising, and innovation. These are broad activities. Obviously, the different NGOs and charities have specialty focuses: water and sanitation, healthcare, maternal health, education, disability inclusion. So all of those factors need to be involved. There's particular skill sets of NGOs that I would define as being important for ministries of health or other ministries that are responding to a disaster or preparing disaster that can be utilised. NGOs often focus on equity, access, affordability and accessibility. They have a role in developing and maintaining standards and teaching, and they have a particular ability, especially charities, to mobilise resources and funding and to raise awareness of the particular issues or the particular disaster. I would say this opens an opportunity for ministries of health, and that's essentially working with NGOs or alongside NGOs and guiding them towards a more collaborative and coordinated approach. This shouldn't be seen as a challenge. NGOs should be seen as a collaborator for the ministry to support, guide and regulate. The World Health Organization last year, I think, or late 2014, released a new framework for disaster risk reduction called the Sendai framework. I won't go into detail about this, but it guides the role of NGOs in risk reduction programs. It's based on an older model called the Hyogo framework, which I've had some experience with in Nepal, where it's essentially a pillar approach for risk reduction and risk mitigation programs. Each of the pillars is led by a particular ministry that is responsible for risk mitigation or disaster response. Ministries of Health and Education, Ministries of Infrastructure, Ministries of Finance have a lead role. Within each of the pillars are the NGOs, charities, civil society or academia that have a particular interest in that area of risk mitigation. In Nepal, it's worked very effectively and was a key recent earthquake in Nepal. My work on that program was actually looking at the cross-sectoral or the cross-pillar linkages of disability inclusion and ensuring that people with disabilities were able to access risk reduction activities, be identified for disaster response activities. Oops. It's also very important to be inclusive with risk mitigation programs. Inclusive communities include women, children and youth, people with disabilities, older people, Indigenous peoples and migrants. Each of these groups have a particular role in understanding or preparing for disaster mitigation, and by naming the subsectors or the inclusive communities keeps them in the forefront of planning. However, risk mitigation and risk responses needs to involve all sectors, and what I've found was missing from some of the literature was the links to academia, scientific and research entities and networks, essentially to understand and evaluate risk mitigation methods, as well as business, professional associations and private sector, including financial institutions. Banking needs to continue in the event of an earthquake, for example. Including private sector in risk mitigation is an essential component, but again is often neglected in planning. I had a question previously about refugees and externally displaced people. Currently, and this is another Global Alliance statistic, nearly 3 million surgeries are needed annually for all the refugees worldwide. However, there are few governments and humanitarian aid organisations that actually plan basic surgical needs when preparing for an influx of displaced people. So in the context of surgery, we need to be able to incorporate surgical services in emergency settings. I think for the interests of time, I won't proceed with this second component of the presentation. But I'd like to thank everyone once again for your attention, and I'm happy to take questions.
Thank you very much. Yes, I think I fully agree. Charities and NGOs has a major part to play in disasters and crisis management, and we saw that very clearly in Libya. In some areas where they were the only care provider, especially areas with internally displaced. And also, you will remember the days when South Tunisia was crowded of Libyan refugees, and the NGOs had a lot of work done at the time to help those displaced people. So thank you very much, Dr. Allen. Our next speaker is going to talk to us about how it is when, how things are when the minister is economist. Now, when the third world, generally ministers of health are doctors, and when it comes to healthcare finances, especially if they're not experienced a lot in the management side, they can be lost, and they basically refrain from reform, because usually you would be very happy with the existing system if you, that may be one of the reasons why our countries were reluctant to embark on development or reforming the financial system over the last 20, 30 years, because like in Libya, we had successful ministers from the 60s who are mainly doctors. Tuvalu, which is a country in the Pacific, has a minister who is economist, and he is going to tell us about their experience. So next speaker is His Excellency Mr. Manuela, the health minister in Tuvalu.
Thank you, Chair. Before I tell my story, once again, I would like to thank my friend, Dr. Okri, to invite me to this very important international forum. Though it's an invitation from the government of Libya, which I'm very pleased to attend, but I would like also to thank the government and the people of Tunisia to accept me into their soil. I have 1 hour to wait in the airport to get my visa approved before I flew over. Nevertheless, thank you again for being part of this family. I don't know why my friend Okri keep on telling me that I'm the economist. Actually, I'm an accountant. And you know that economists and accountants, they don't go well, especially when they are talking about figures. Well, you can be an accountant and be an economist at the same time, but vice versa, you cannot be. Anyway, he's been giving me a very hard task to conclude and wrap up all the presentation from day one until the last moment and the last speaker. And I'm, over the night, people are telling me, have you a good sleep? I always say yes, but they don't realize I didn't, because I have to stay awake and make sure that I have to diagnose whatever has been presented here to give you some sort of solution to what we're trying to discuss here. And I have come up with a solution that I have to talk from my experience in a developing country like Tuvalu. Tuvalu is made up of 8 tiny islands that make up the country, right in the heart of the South Pacific Ocean. The average height of these islands is about below 1 meter. So you can see the kind of island where I come from. The widest part of the island is less than 2 miles. Otherwise, most of the island is about less than 100 meters wide. And you have the sea on both sides. And that is the kind of environment that we live every day of our life. As a Minister of Health, I think I'll talk on 3 topics. And that is on the curative part of it, public health or preventive, and financing the ministry. I came into the seat in April last year, and it's a hard task for me with all the information that we know about Ministry of Health. So I think to make changes, it's the Minister of Health to make changes, and they have to convince their cabinet members to realize what's really happened in the ministry. If you don't, then you fail. It's not the ministry, it's not the government, but it's the minister himself. That's my principle. So what I did, I make some few changes. Before I talk about financing, I'll talk about improving our curative. Our doctors, most of them, are not specialists. They are only general practitioners. The training is such that after their training as general practitioner, they stuck there for years. We all know the criticism that we have in our medical, especially when our doctors are from our own national. They don't trust us. And that's what happened also back home. They prefer to go overseas. So I came up with the idea to invite and engage some specialists from the region with a high price. But I have to do that in order to have the confidence in the healthcare. I started off with establishing a reform in the Ministry of Health. I gathered all my staff and we brainstormed what to be done and what will have to be reformed. And most of the main objective is to reform the management of healthcare so that we can deliver a healthcare that will look after everyone else. We managed last year to engage a few doctors. The reform that we established last year is a 4-year term, and that will have to coincide with my term. I don't have to have a reform that someone else have to take, to deliver that one. I have to make sure I deliver my reform, and that is the strategy. That reform also is included in our national strategic plan, which is a 5-year term. It started in 2006 and in 2020. Our reform, the same year, we start 2016 to 2019. My aim, I have to make sure that I have to deliver what I have promised. The objective of the reform is to better manage the services that is available at that point in time and the resources that we have. That's the aim of the reform. At this time, we are not thinking of getting extra money from somewhere, just to get what we have at home and to work within our means. We have to review the suppliers that we used to get our drugs from. They haven't explored a lot of places where we can cheaper price, essential, but safe drugs. And that's what we've been doing. We have also to improve our capabilities in our lab with the assistance of some of the agencies in the region, and that is WHO, SPC, UNICEF, and so forth. We also have developed in our reform to build better clinics in the outer islands and 2 hospitals, one to look after the 3 islands to the north and one in the central, for the 3 islands in the central, because the existing one is in the south, where the capital of the country is. The clinics in the outer islands, there are many factors into that one. One is that we have to make sure that we have the services right, not for them to travel to the capital. To per patient. That's how expensive. So the long term is to build this clinic here and to man them with the doctors and the nurses so that it's available there, the services. Not only that one, if we are looking at disaster, our experience on disaster in Cyclone Pam last year, assistance from all over the world, it's stuck on the capital. They came by plane for 1 to 2 weeks. Why? Because you have to go to the outer island, you have to go through the reef, and all the big waves are there, no one can go there. We don't have any seaplane, we don't have any helicopter to drop the assistance. So the aim to improve those is to make sure, is to facilitate islands. Anything happen, and there is a delay for assistance, they can cope. That's the whole plan. When I came in last year, we have a budget for our referral for tertiary treatment overseas. Toward the end of the year, we ran out of the budget. And there's a lot of sick people. You don't know who is going to allow to go and who is not. As a politician, I raised a case in cabinet. I told them, a cabinet paper, I'm going to return all the patients back home from tomorrow. And the Prime Minister was serious about this. What is wrong? I don't have the money. So if you don't give me more money, I'm going to return them. And what happened? They give me more money. So it can happen if we, the Minister of Health, can fight the case. And then I make a proposal this year to double the amount. Because giving a justification that the budget is always over or less than the actuals that we have. These are the kind of things that us, Minister of Health, can sort of convey the message to our cabinet members. They have to know what's really wrong in the ministry. Otherwise, we won't be able to improve our Ministry of Health. In the meantime, we also, for our curative, we are sending our doctors to further their studies, while the specialists are taking over the operation of our hospital. We have to remember that training a doctor is not 1 or 2 years, it's 4 or 5 and so on. So the problem that I face is that the training for our doctors to be in that level was not done for many years. And that's what I face. So we have to train our doctors. We have to send them overseas to get qualified and to do better, so that the confidence of our people will be there. Because we experience also at home that our own people don't have the confidence in our own doctors. So the only one way is to train them and then get them qualified. Hopefully they can work with our overseas specialists so that we can have the confidence back to our own hospital. We're also trying to create an information system. We don't have an information system when I came in, because it's very vital to have an information system. We don't have accurate data, everything is all over the place. So having an information system that can harmonize to get all information that we have, because what we provide to WHO can reflect a bad image on our country if we don't have accurate data. And we are working with that one, with our partners from Taiwan, that are offering the software. We don't pay for it. This is how we go around and ask for assistance. So we are not paid for any the software, and we are asking also the nearby University of the South Pacific for their personnel to come and assist and harmonize the whole package. So there's a lot of other things that we're trying to improve our curative part, and also at the moment now we are in the process of asking our friend who can donate some of the equipment so that we can do a lot of checking, especially the diagnostic moment. Last year, we have to send most of our patient referral just to get the CT scan in Fiji, because we don't have one there. Any minor checking, we don't have those equipment. So every time we have to send them, that's money, because accommodation and allowance is there. So those are the cost-cutting things that we have to look at, and that's what we are doing at the moment. So by advocating what we have in this kind of forum here, we get the assistance, and we just are very appreciative of that one, with some of the agencies that are helping us. Now we come to the very important part, what I call that can solve, and that is public health or prevention. I was concentrated on the curative from last year until the end of this year. And then everything seemed to be in place, but we have to review as we go along. Next year, in the month of February, we're going to have the first ever national forum. And I'm going to invite all the stakeholders. I know our population is very small. It's about 12,000. And I hope that the only way to solve health issues is to go and visit the people. So I'm inviting, because we have 8 islands, the heads, the chief, the councillors, the women leaders, the youth leaders, and whatever grouping, organization that you have in those small islands, I'm going to invite them with all the departments who are linked, because it's a cross-cutting ministry, and all the NGOs, the religious leaders. I believe that if we reach out, even we have to reach out millions of people, that is the solution. Because from here, we listen to the problem that they have. Sometimes we predetermine what is wrong with them, and we make a lot of costing and a lot of policies from up there. But nobody really knows what is happening under the ground. So we decided that we have to go and reach out, not only that we have to invite them to talk about what is really wrong, but we have to educate them on the things that I listen here, or what we have learned from all the meetings that we attended with my staff. Because sometimes you just go to a meeting and you come back and you make policies. We have to convey that message. If we are talking about SDGs, they don't know. They don't understand what WHO wants. This is the only way to them. In Tuvalu, we don't have TV. We don't have newspapers. We only have radios. So the only way to convey message is person to face. So we have to spend money to bring those groups. Not only that one, we're going to have this activity as an annual forum and then review everything that we have. We have to educate them a lot of things, hygiene and so on. And the danger about getting sick. The aim of this forum is to minimize what we have experienced now, whatever kind of disease that we have. And that's the most important thing. If we can improve this public health or preventive, I'm running these 2 programs simultaneously. While we improve our curative, we have improved also our public health. And at the end of the day, we'll have to divert the unnecessary cost that we invest in the curative to public health. I believe that if we have a healthy population, then we have a healthy nation. Not all people are employed. Only 20% to 30% are employed by the government and some of the companies. About 20% self-employed. Another 10%, they receive remittance from the diaspora that's overseas. And the rest, are not employed. If they are healthy, then we can engage them in the private sector. I have listened to a lot of presentations that sometimes when people live longer, they'll become an issue to us. My grandmother passed away when she was 94 years old. She's not sick. She's not admitted to a hospital because we have those kind of principles that I'm trying to apply now to the Ministry of Health. It can be done. It's not hard to be done. If she eat very basic food, you have to live in a very small house, and she lived at 94, why can't we? I mean, we have a very complex community nowadays. We want to study overseas and we bring all sorts of ideas. But then now we are complaining because we get sick because of the food we import and so forth. But yet, we have a very basic principle that our system. In Tuvalu at the moment, all healthcare is free, even if we have to send you overseas. So we're going to regulate that one so that we can be able to screen every people that we visit. This way we can have a very accurate figure on what is really wrong. And then the idea of take, especially the leaders of the community, because if they realize what you're trying to convey to them, they will take responsibility for their own people. Even if you have to raise the tax for tobacco, we have to explain to them. If you are smoking now, if you want your children to have this problem, you have to think twice. This is the importance of talking to the people. And that's why I'm really encouraging this forum here to be an annual event. Whether it's 12,000 or it's 12 million, it can be done. Because that's your new way solution, I think. It might not be able, but if we try, I think we can solve the problem that we're trying to solve now. We are thinking also exploring some medical traditional treatment and medicine. We are working on our lab if this can be done. I mean, everybody have experienced that one. In my time, I have experienced local treatment that works. But we have to encourage this one into our medical system. In 2012, I initiated what I call a forum for my own community, where I encourage all the diaspora from my community to come down to our island and share the experience. People who are working in government share what are the objectives of the 2014 and 2016 in the month of December. What happened about this one? Understand what is happening around them. And it have worked. Now government is assisting the diaspora and they are fair to go back. And they are assisting what they call the councillors to establish what they call island strategic plan, to be in line with the government strategic plan. Before, it doesn't work. They do their own things. It doesn't go along. And they want more money. Just like us, any government, when you ask donors, sorry, you cannot have money because this one is tied up with this one. That's the same thing we're trying to explain to our communities. It's working now. Encouraging the diaspora to come down to their community and explain and assist them in the way of thinking so that they can progress and all the projects that they want to be in line with government. the private sector. Myself also at the moment, I am the president of the private sector of the country Tuvalu. And I'm encouraging and I'm fighting population that we encourage them to have self-employment. In Tuvalu, when you turn 70, you have an allowance from government, a monthly of which can come down to 65. And I say no. And the problem that we facing now in the whole world. We can advocate also lifestyle, the eating habit, the attitude. We encourage the families because we have to target the families, the parents. Nowadays, a lot of youngsters, they want to get married, but they don't know how to look after their families. We have to educate these people because if we don't, and they have children, they don't know how to look after children, they will get sick. Having fever, go and sleep. It's creating a number is thing for rheumatism. But because the people, why this disease is created, that's why we have to educate them. We have to dialogue with them and prevent this one without any treatment. An institute where we're going that we can engage youth to go out to the public and educate our people. So that's the very important thing that we're going to establish, and as is the institute. We can establish that one with minimal funding that we can have from government and maybe for our partners as well. I want to close with a few comments on funding. Government have a budget of 45 million for the whole government. We have a share of 8.5 million. 40% of that one is wasted on referral cases. And we have a population of 12,000. And you can see there's a large chunk of that one used for referrals. So I created what I call is a health trust. The whole idea is to subsidize or to sustain some of the activities or the program that we have in order to sustain our health programs in Tuvalu. And we have come up with an idea that for every project that is given to Tuvalu WHO, so we're going to charge a 10 to 20% of that one should go into that fund. And all the tax that we're going to levy on foodstuff, commodity, on tobacco, part of that one have to go to this fund. And then we working on an idea, what you call here is medical insurance. The way we are looking, we have what we call a provident fund, where you, as a working person, you contribute to your fund. And in that contribution, a percentage of that one is put aside for your health. So we discuss with the Provident Fund if they do a collection for all people who are working, because the law is that for any employment, for any income you earn, you must pay your Provident Fund. So a fraction of that one, what we can call it your contribution to your medical, will be also coming to that fund. There will be a small percentage of those who are not working, but we are looking at ways on how not. But that's the insurance that we have in order to contribute to our fund. And that is through Provident Fund. We are not calling it, they collect it. But at the end of every year, we will transfer that one to our fund. And we have to live on that trust fund on the dividend. We don't utilize it. Whatever dividend we receive, we roll on some, and some we have to look at the services that we want to fund that one. And I'm advocating that one to the countries that we deal with, to the companies that we come across, if they can contribute. Because here in Manila, I was discussing, because the Global Fund now been established, that's for climate change, not for health. You cannot go directly there for health purposes. So I'm nagging that WHO can be accredited to access this global fund so that we can go through WHO as an accredited agency to give some of our projects, because at the moment we cannot go for health directly to global. That's why I'm nagging that WHO can be an accredited agency so that we give our project. WHO is the only agency that understands what we are talking about, not UNDP and so on. And I hope they will be able to be given the green lights to be an accredited agency. So those are some of the things that I am applying back home. And I hope it reflects some of the things that we have discussed in the last 2 days. So that's the way to finance my ministry in having this health trust. Because with this health trust, I can do a lot of things. It's infrastructure, whatever program they have. It's harmonized all that. Because some of the funds that we receive from agencies, they tap. And some of the country also, this one is for this one. You cannot use it for someone. And that's why I don't like. It has to come here so that we can use it in our own capacity, in our own pace. Because sometimes they come here, you have to do this one in 1 or 2 years. But sometimes we don't have the capacity. And when they left, they want us to meet the cost, the human resource and so on. That's why I'm charging them 10 to 30%. It's not popular, but I'm doing that one. I hope everything that I helpful, but thank you for listening to the presentation. Thank you.
These small islands in the Pacific, we always imagine the nice beaches and being there on holiday, but obviously they have their own problems, and whether you are a giant country like the United States of America or small country, I think the issues in terms of financing is the same. Healthcare is becoming very expensive, and if systems continue the way they are, it will become unaffordable. So affordability is the main problem. I mean, we need to reform things related to efficiency. But I think everybody is moving towards contribution-based system, and I know my colleague and friend Dr. Rida is very passionate about this. He is even more passionate about health-saving accounts, but I think for Libya, to me, whether it is health-saving accounts or national health insurance or any other form or hybrid system of both will work, because it will add personal contributions, so it will increase the money available and the affordability. But before we can succeed in that, we need to reform our system and make it more efficient, more reliable, and try to minimize money wastage. And I know my colleague said we can't say corruption in America, but I think because things are so bad in the Middle East, we can freely talk about it. So we need to sort this out before, I mean, probably go side to side with choosing the right system forwards. But no system will succeed in the current atmosphere of poor efficiency and money wastage. And healthcare is becoming really very expensive. So we need to reform. There's no doubt about it. Almost it doesn't matter which financial model you will take, as long as it is based on contribution. So with these words, I think we are coming to the conclusion of this meeting, and I would invite Dr. Rida to say some closing remarks. It has been really enjoyable 2 days, and I certainly learned a lot from this. So Rida and Dr. Mahdi, you want to say something?
Sorry, well, like saving the time, actually it's time running out. I will just shortcut what I'm going to mention. It's about health financing systems. I would like to thank Dr. Sati, the Ministry of Health of Toval. He's coming all the way from the middle of Pacific to sharing his experience, and it is tiny, lovely countries somewhere in the middle of Pacific. Really, we do appreciate his coming, actually. And whether this financial system or financing system is applicable, I will just go through different financing systems in the world. Number one, the tax-based health financing. I will give some examples. For example, it is quite common in, commonly used in UK predominantly, and Australia, Canada, and Finland, and Sweden, and Portuguese, and Norwegian, Spain, a European country predominantly. By the way, there is no financing system which is optimal, but there are different financing systems. This one. Everyone draw revenue from taxes and non-taxes governmental revenues. The other system, which is quite commonly used in Germany, which is social health insurance. We are raising questions more than answers, whether those systems are applicable in our regions, in different countries. The experience shared by Dr. Sethis in his regions, it's lovely tiny countries, whether those systems are applicable or not. The other systems I will go through quickly is actually private health insurance. This is another system which is delivery arrangement, direct contact with providers, public and private. Predominantly we found that's in the United States. Obamacare, which is based on that. As Professor Oakley showed his slides, the income of, at some stage, family income is not able to cover the health insurance, which that's disaster sometimes happening. Another example, which is medical saving account, it is a success in Singapore. One of the example of the success we mentioned. It is applicable for certain countries, not applicable for Tunisia, not applicable for Libya. Our systems in Libya, we are concerned about Libya, Tunisia, Maghreb areas. I thought we need reform our systems, which is applicable for our regions. It is need really efforts and work, research, teamwork actually, by help of expertise to reform system which is applicable for our regions. And then finally, this expense about out-of-pocket system, also another system which is available in these countries. That's directly outlet of cash that may be later reimbursed. It's really very costly for population or for people or for families. That system is, at the moment, predominantly in sub-Saharan countries. I thought we are in sub-Saharan countries somewhere, Libya. A lot of out-of-pocket, which is still shameful, actually. The nations of the world is divided to different countries. Super rich countries, or rich and poor countries. I thought we're rich and poor. What does that mean? Rich in paper, but realistically it is poor, because healthcare delivery is very poor, actually. That's sort of examples. We're raising the questions rather than the interactions. Also the role of NGOs. We're asking questions at the moment in Libya. situation. We are in a real, very critical situation, extraordinary situation. We're raising questions. The organizations, all the organizations, charities, NGOs, able to provide what's necessary, what's essential it is actually. It's not, we are looking for the essential, the minimum. Whether the organizations such as WHO and other charities, that's why NGOs play a big role. I'm very happy that Dr. Ibtisam and Dr. Anwar, they are here, and they're looking after a lot of displaced Libyans everywhere, predominantly Tunisia, Algeria, Egypt, everywhere. Internal displacement, external displacement. They need health care providing. They need care, medical care actually. So whether they are able to interact, let's just ask questions. We don't know, we ask, it's just we are in the middle of crisis. We're just trying to do something and brainstorming and try to keep going. We're just raising questions more than, that's what we called to pull or not to pull, that's the question. To pull or not to pull, that's the question. We're raising questions rather than answering. Many systems, financing systems are. Is it applicable in Tunisia? I don't think so. We're in the mess. Ordinary situation. Unless we created something applicable for our regions. I'm going to stop there. And I would like to ask Dr. Anwar and Ibtisam if they would like to share any experience about the district, but we are in extraordinary situations, especially
been in these years أو لي الآن أكثر من عامين في هذه الوظيفة. سأتكلم باللغة العربية عشان المترجم. كانت أيام صعبة والعديد من زملائي الدكتور مصباح العوامي، أستاذ نوري، أستاذ فتحي وكثير من الزملاء، الشيخ طاهر، يعلموا أن نحن كنا يعني ولا زلنا نعمل في ظروف صعبة جدا. يعني قلما ما كانت فيها لحظات السعادة. لكن الآن في هذا السيشن أنا أشعر بالسعادة العارمة، لأن فعلا عملنا بجهد لمدة أكثر من سنة، منذ أن تحدثت مع وزير الصحة دكتور سعيد العايدي من أكثر من سنة من أجل إنجاح هذا المؤتمر في تونس. الآن أنا سعيد جدا هؤلاء الناس. طبعا أي نظام صحي كما التمويل، الموارد البشرية، صدر المعدات المعلوماتية وتقديم الخدمة، وأهم عمود في هذه الأعمدة هو التمويل. وكما أشار متحدث نيابة عن منظمة الصحة العالمية، أن الفكرة ليست فقط في الوارد أو جباية الأموال، هي الفكرة كيف تتصرف فيها وكيف تنفقها وكيف تضمن استمرارية هذه الجباية. هذين الأشياء أساسية. لو أنك عندك دولة جديدة بادئ من الصفر ممكن تختار أي نظام وجيت تطبقه ما فيش مشكلة. لكن كل دولة عندها خصوص يفكر في موضوع الكو بيمنت كبديل للميهم أو مثلا لموضوع التأمين الصحي الاشتراكي. السيدة مارغريت تاتشر رئيسة وزراء بريطانيا سابقا لمدة 11 سنة والأكثر قالت كلمة، قالت المشكلة في الاشتراكية أو الشيوعية أنك عما قريب ستستنفذ جميع أموال الآخرين. يعني هي قالت the problem with socialism is that very soon you will run out of other people's money. فيجب أن يتم إشراك المواطن. يجب على المواطن أن يشعر أن هذا الإنفاق ليس أموال آخرين بل أقل جزء منه هو، لأن لا أحد يعني أن نفكر أن في شيء اسمه خدمات صحية بالمجانية، هذا الشيء للأسف سطحي جدا. هنالك من يجب دفع تكلفة هذه الخدمات الصحية، يا إما تدفع عن طريق التاكس أو الضرائب، أو ستدفع عن طريق أموال الدولة في حالة ليبيا اللي هي الوارد من النفط. ما فيش حاجة اسمها خدمات صحية بالمجان، هنالك من سيدفع تلك الخدمات الصحية في يوم من الأيام. وأنا أرجو أن استمرارية هذا المؤتمر بتكوين لجنة أو مجموعة تهتم وتنظر وتحاول تجد ما هي الخطوة القادمة التي يجب اتخاذها. هل حيكون مثلا دورة تدريبية للعاملين في قطاعات الصحة في العالم تقام مرة في السنة، ولا هل نعمل نفس المؤتمر ونحاول نقويه بخبرات الناس؟ الدكتور علي مقدات وعلاقاته في أمريكا خاصة بالبنك الدولي كان غايب بوضوح، يجب أن يكون له دور في هذا. كذلك نحتاج يعني وجود أقوى من منظمة الصحة العالمية وكل من له علاقة بتمويل قطاع الصحة في العالم، إلا التركيبة الصحيحة، العمل على إيجاد نوع المحاضرات، اختيار المتحدثين، اختيار رؤساء الجلسات. لم أعمل أكثر من ذلك، صح كان مجهود اللي أدى هذا الفريق يعتبر مجهود بسيط إلى حد كبير. أتقدم بالشكر الجزيل لجميع المتحدثين وجميع المشاركين ورؤساء الجلسات، وأخص بالذكر السادة الوزراء، وعلى رأسهم الدكتور سعيد العايدي، الدكتور رمضان، سيد نائب رئيس الوزراء من طرابلس الدكتور عبد المنعم الدالي، معالي وزير الصحة توفالو الدكتور ستيني، ومعالي وزير صحة غامبيا الدكتور عمر سي. أخص بالذكر كذلك الذين أداروا هذه الجلسات بنجاح، وعليهم على رأسهم الدكتور مراد القريو والأخوة المتحدثين، وكذلك السيد خالد طبيب المذيع البارع الذي يعمل لدى قناة 24 الذي أدار الديبيت أو النقاش بالأمس بنجاح واضح للجميع. فنرجو إن شاء الله حيكون بيننا اتصال، وأن نبقى على اتصال إن شاء الله، ونجد ما هي الخطوة القادمة من أجل دفع هذه الأفكار الجيدة جدا، والتي من شأنها إن شاء الله لو نجحنا نحن كمجموعة بإقناع دولة واحدة فقط أن تعيد النظر في طريقة تمويلها للصحة، هذا عندي أنا حيكون نجاح كافي. ولكن نأمل أن هذه الرسالة تصل لأكبر عدد ممكن من الدول. سيكون هناك غداء للسادة الوزراء والسادة المتحدثين ورؤساء الجلسات، إذا هم عندهم وقت أرجو منهم أن ينتظروا في اللوبي هنا في فندق شيراتون الساعة 1:30. ومرة أخرى أشكر الجميع والسلام ورحمة الله.